Hello, everybody, and welcome to How Can Innovation Tackle Global Health Challenges? My name is Ashley. I'm from the Singhal JIC NUS Global Health Institute. And together with my team and colleagues from the JIC NUS Office of Innovation and Entrepreneurship, we are pleased to present this webinar to you today. During this session, we bring together healthcare innovators and leaders passionate about healthcare innovation to explore whether innovation is truly transforming healthcare systems and outcomes and how it can be done better. We'll hear from our panel of esteemed speakers as they share the good, the challenging, and the inspiring from their work across industry, startups, and community health. To our participants, just one little housekeeping thing. There is a Q&A button, so feel free to post your questions there, and we will get to them later during the Q&A segment. All right, now I'll pass the floor over to Associate Professor Jonas Karlström, our moderator for this session, who will introduce our panelists and also get us started. Jonas, please.
Thanks, Ashley. I'm thrilled to be with you here today and to be the moderator of this discussion together with our esteemed panelists. We'll be diving into the question as titled of how can innovation tackle global health challenges? This directly, of course, corresponds to a new graduate certificate that we'll be offering up together with the Office of Innovation and Entrepreneurship, as well as with Singhal Innovation. And I have the pleasure of being the program director of our new graduate certificate that focuses on global health innovation. But back to today's discussion, and to help us to respond to this question and bring their own unique perspectives, we have our esteemed panel with us. Our panelists will be sharing different perspectives based on their own unique experiences of tackling complex issues of healthcare access through innovation, including in low and middle income settings. So let's kick things off with introductions. First off, we have Dorothea Dotko, CEO and co-founder of BotMD, a Y Combinator-backed startup that is building an AI clinical assistant for doctors. Since 2018, BotMD has been used by over 20,000 doctors globally and has helped to impact over 55,000 patients within Southeast Asia. Currently, with 10 patents published and pending, Dot brings to this conversation her experience in the health innovation startup space. Next up, Shams Shabab Haider, Health Data Management Project Lead at Friendship NGO, which is a leading non-governmental organization in Bangladesh, dedicated to providing healthcare education, legal advice, and breaking down legal issues, as well as climate resilient development to underserved communities. Shabab oversees the design and implementation of data-driven strategies to improve healthcare delivery and access in remote and vulnerable areas. And lastly, our adjunct associate professor Alok Mishra, he's the CEO of medtech consulting firm Value Addition and former vice president at Johnson & Johnson Medical in Asia Pacific. He's also co-director of one of our modules within the graduate certificate in global health innovation. Alok has developed an academic framework to help an access innovation model unpack for innovators access issues and create innovative solutions that aligns stakeholders towards removing bottlenecks and achieving a common goal, patient access to healthcare. First off, I would love to hear more about each of your personal journeys. How does your current work in innovation help to address issues of health access more specifically? Dot, if I may, start by asking you if you could share a pivotal moment in your startup journey that has shaped your approach to innovation, and feel free to also make any comments to how healthcare innovators more broadly could be thinking around access.
Sure. Thanks, Jonas. If you don't mind, let me share actually a couple of pictures because I think it helps contextualize a little bit about why I started BotMD and what we do. So I started BotMD about 5+ years ago. And actually many people don't know this, but the inspiration for BotMD actually started when I was in Indonesia. All right, so everybody knows like Indonesia, you've got like 17,000 islands. And this is an actual photo of a GP in the middle of nowhere, Solo, Indonesia. And the idea for BotMD actually started here, right? So if you take a look at the photo, you'll notice that she doesn't have any computers, right? Similarly, she doesn't have, an EMR. sitting at a desk, all right? And my question to her is, what do you do when you don't know what to do, right? This is a doctor like 2 years out of school. And what she did is that she actually showed me her phone, right? She said, okay, well, when I don't know what to do, I actually go online, I look up Google, I look at Netscape, MIMS, right, for drug data. But then more importantly, she actually opened up her chat app, right? So that actually really inspired me. One, I didn't like the idea that doctors were Googling stuff. So I actually wanted to build something that, would be able to immediately reply, similar to the way that they actually chatted on WhatsApp, right? So the goal of BotMD is actually really to make it quick, make it very reachable. And going back again to global health, one thing that I knew would be that I needed to get to them through phones, right? Because they may or may not have laptops, right? So then I actually took it to the Philippines, right? And then in the Philippines, actually discovered that very similar problems, right? 7,000 islands, very remote. Many people travel like hours to get to care. And in the Philippines, about 90 million Filipinos actually already use Viber and Facebook, right? So we actually then started to build out reach through chat to actually help clinics and hospitals automate the delivery of care using chat apps. So to me, actually, the inspiration for BotMD, weirdly enough, actually started in Indonesia, and it started with the question of how do I reach doctors that are in the middle of nowhere, and do that at scale. Yeah.
Really, really inspiring and interesting how you just started from this very, very natural kind of conversation-based dialogue interface, and how you got straight to work on that as an entrepreneur. Alok, I would love to hear from you how you, as a high-level leader in a multinational, have worked on fostering innovation in a larger organization, and how you think about touching the barriers to implementing healthcare innovation at scale from that point of view.
Right. Thanks a lot, Jonas. It's a great pleasure to be here today. Innovation and introduction of innovation and scaling up innovation has pretty much been most of what I've done in my life of maybe 40 years in the healthcare industry with pharmaceuticals as well as medical devices. Because whether you're a marketer selling a new type of technology or you're in global health, the issue basically is I have a technology, I need to get it to patients, and in between something is not happening, there are barriers. And you see this even if you look at the Lancet report on global surgery. Again, 5 billion people don't have access to surgery. So there's some things which are not working. So I started off, I remember the first thing, this goes back 1985, it's a very long time back, looking at depression in India. And you found that the market for depression was very small, but 2% of the population was depressed, which is like the size of Australia or Malaysia. So many people were there, but they're not getting to the doctor. So there's something missing there. And I realized that the challenge here was they were not able to reach the, say, psychiatrists or the specialists because of the referral systems not working. So in that case, it was the GP not being able to identify depression and therefore not sending him forward. Then later on, I worked with insulins. So you would think it's a no-brainer that people who have diabetes, after some point in time, they need insulin, they should go on it. There was very little penetration of insulin. At that time, I used to work with Boots and Novo Nordisk at that time. And you realize that there was a big barrier with the doctors in terms of they didn't know when to switch from tablets to insulin. So there's an education piece with the doctor, which is why they were not adopting the new technology. Come from there, I came to Johnson & Johnson. That was about 1997, 28 years back. And I realized I was in charge of stents at that time, angioplasty and stents. And then I realized that there are a couple of things missing here, which were more than what I'd seen in pharmaceuticals, that surgery needs equipment. It needs ORs, it needs cath labs. Then only things can happen. And also, stents were not cheap. It was at that time, it was $2,500, so people couldn't afford it. So when I started looking at these, I realized there are 4 essential barriers when it comes to either introduction of or scaling up of innovation. So I don't know if I had one slide with Pushpa, if you could put that up.
Yes, just give me a moment.
Yeah. So that will be easier for me to talk through. So everyone possibly has heard of these barriers, but how they work is something which I try to figure out. So there are 4 of these. So the first one, let's stay in the middle, the 4 A's, which I call the access, which is whether you have the equipment, whether the products have been approved, whether you have the consumables required, all of that. You have hospitals, beds, and stuff like that. So that's the first thing. That is critical, without which you cannot have surgery, but that's not enough. You need to have physicians who have adopted or have been trained in that surgery. So while cath labs were important, if doctors were not trained in doing angioplasty, you would not have any stenting happening. Again, all of this would not work if the patient, as I mentioned in the case of depression, was not reaching the right doctor. So awareness with patients and the whole referral chain needs to work. And finally, none of this would work if you could not afford it. But what I figured out, it actually goes in that sequence. You cannot go down. So if you think of each one of these as a barrier or bottleneck, you have to make sure that you have the availability and access first. Then the physicians become important because now you have stuff available. Then the patient flow becomes important, and finally affordability. If you solve it the other way, you will not get treatment. So for example, I don't have cath labs, I don't have physicians who are trained, and I go and give universal health care. You will not get a single angioplasty done because there's a sequence in which you have to remove the bottleneck. So this was my finding, and then I used it in every new launch which I did. And you realize that suddenly the market wasn't as big as you thought it was. You won't believe it at that time, and this is, I'm talking about 97, 98. The market for stents in Singapore was 3 times that in China. Because China didn't have cath labs, they didn't have doctors who were trained. And looking at this, then we started realizing that in LMIC especially, you find the first thing that is, of course, the cath labs. Indonesia had 2 cath labs, so they could never treat 240 million people at that point in time. But then training of physicians quickly becomes very important. That is a controllable by large multinationals. Setting up cath labs, not so much. We could just talk to providers and policymakers to see if that could happen. So then a lot of work, if you see, happens. And I think it applies even to global health. Building physician skills and training them became a big part of what we used to do. In case of angioplasty, of course, patients referral wasn't an issue. In depression, as I told you, that was a big issue. And even when it comes to things like arrhythmias and all, it becomes an issue. So the point I'm making is these barriers are a way of sort of slicing and dicing the problem, because each one of them has a very different solve. If you don't have infrastructure, there's no point in you start spending money in getting products reimbursed or working with GPs or working with physicians, because you don't have cath labs. So I remember in Vietnam, there was no cath lab at that time. Brunei didn't have any, and Myanmar didn't have any. So you had zero angioplasty there. When they had cath labs, they didn't have doctors. So there were Singapore doctors who would go to East Malaysia and go to these places to do angioplasty. So it actually works like that. So I have seen it in practice. So the way I saw this evolving is like this. Now, from this, therefore, comes the question of, therefore, why are the stakeholders important? And the stakeholders get very important, especially their interfaces with, say, the government when it comes to infrastructure development. And with physician training, academia becomes very important. So though initially in innovation, academia is very important in getting the clinical trials through, training of physicians is something which is very crucial to medtech and to surgical procedures, because every new medical technology, new medical procedure needs retraining. No matter what you learned in your medical college, you still have to go through that. So you find that a lot of work goes on there. Awareness is an issue sometimes. I've seen that happen with knee arthroplasty in places like India. And affordability, of course, everyone generally focuses on that because most people think access is about money. But in our markets, in Asia and LMICs have found, the other barriers tend to become very important, at least initially, till you can work out the others. So that is the framework I've been using. And I find that you can apply it either to a new product launch if you're in a multinational, or if you're trying to solve a problem for global surgery of trauma not being treated properly in a village, because you can actually quantify these. So you can actually make equations for these and say, okay, my bottleneck is that I don't have enough beds in Vietnam. So unless this bed problem is solved, there's getting more physicians there is not going to do much for that. But if you are able to solve it, then physician training becomes very important. In some places, and I think in global health, Jonas, you would have studied a lot about what goes on in Africa and Malawi and all of that, how there are not enough physicians. So how do you come up with innovations, which are not product innovations, but training innovations of getting more people in the skills area. So I find this very interesting. So for the last, maybe ever since I think joined Duke anyways, I've been very focused on looking at how can we help people who are trying to innovate to use this framework to unpack the problem, because trying to solve everything doesn't work. In fact, even trying to solve one of them is a lot of work, a lot of stakeholders, a lot of things have to be moved. So if you try to do everything, then you'll just get frozen, and it's not going to work very well. So that's been my passion. And how do you try to bring it down? And again, it has to be done at a patient IPU unit, and which is where value-based healthcare works quite well, or it can be done at surgical procedure unit. You can do it at a hospital level, you can do it at district level, you can do it at a country level. So at any level, whether you're planning big time or you're planning to solve your local problem, the structure works.
Thanks so much, Alex. That's very interesting to hear how you, from your standpoint of being the leader in the multinational corporation, working through seeing the actual bottlenecks in these different markets, have developed this particular framework of from practice in a pragmatic way, solving each bottleneck at a time, and then being able to stitch that together in this new approach. Thanks very much for sharing on that, and also highlighting, of course, that there's many different types of needed innovation. We can go about innovation in a lot of different ways. Shabab, I would love for you to also share some of us with the audience from your ground up perspective. How has health innovations enhanced patient outcomes in the settings you've been working, and with the particular innovations that you've been involved with? Feel free to highlight any particular successes that you have enjoyed, or also any of the main barriers, which are very important to recognize as well. Over to you.
Sure. Thank you, Jonas. Yeah, so I guess the best way to start would be discussing a little bit about Friendship, the organization I work with, and kind of the context in which we work. So we're based primarily in Bangladesh, and basically you have many NGOs in Bangladesh, but the area that we specifically target are the people living in the Hartrees communities called Chors. So Chors are basically riverine islands. If you see in the map of Bangladesh, you'll know there are many, many, many rivers. And on those rivers, you have islands that build up. Basically, it's the silt from rainfall that condense into an island that temporarily exists for as little as 6 months, as much as maybe 2, 3 years, 10 years even. But at some point, they'll disappear. The interesting thing about these islands is because it's made almost 100% of silt, it's very great for crops. So a lot of people, especially economically deprived, they move to those islands. They live off of subsistence farming. They'll stay there as long as possible, and then when the island disappears, they'll have to move somewhere else. And this is just the cycle of their livelihood. So there's a couple of pictures I have on the slides here to give you an idea. So you'll notice, actually, can you go back to the previous slide? Yeah. So to give you an example, if you look in the right side picture, on the top of the island, that's where the silt is forming, it's coming up. And then on the bottom of the island, on the left side picture, you'll see that's where the island will start to dissipate. And so that will happen over time. But then sometimes, if you go to the next slide, you'll have big rainfall events, every year we have flooding and that kind of thing. And so the island could just overnight disappear. And people will have to quickly move to another place, and, lives are lost and property damage and all kinds of stuff. So this is the context that we have to work with in Friendship. How do we provide healthcare to these people? How do we provide education services, legal services? The way Friendship started 20 years back, our founder, Nakan, her idea was we have to take the healthcare to the people. We can't expect that anyone living in these kind of conditions would actually go to a tertiary care facility in the city, or even any kind of primary healthcare facility living in this kind of situation. So in the next slide, you'll see. So these are the ships that we operate at Friendship. We have a total of 7. And so these are totally, like they're equivalent to like a tertiary care facility. We have doctors who perform surgeries and, all kinds of stuff. Uh, and also as well as like basic primary healthcare services. So these will go to these remote communities. They'll dock there for, let's say 2 weeks or a month, and they will provide the services for the people. We market to everyone in that area that, okay, there's a Friendship ship. It's free to access. Just come, tell us what your issue is. Sometimes what we'll do is we'll survey the people in the area beforehand to see like, okay, this many people have like cataract issues, or this many people have like hernia or something like that. Okay, and then we'll contact a doctor team. Okay, come to this area, stay on the ship for 2 weeks. We'll bring the people to you. We'll perform those surgeries. So the thing is, so when we discuss innovation, really, we need anything that we can get. Alok mentioned before that we have not just the innovation in terms of product design, but in terms of getting people into these areas. Staff shortages, like, so the interesting thing about Bangladesh is our infrastructure of healthcare services in the rural area is actually quite strong. We have tertiary care facilities, secondary care facilities, community clinics. Basic, every single district, every single sub-district has those facilities, but they'll have doctor shortages, they'll have medicine shortages, they'll have equipment shortages. So that's, where organizations like Friendship come in, and so we can help bridge those gaps. And then at the same time, we also do need those kind of product innovations, like Dot was mentioning. We have a similar thing. I guess I'll discuss it in a little bit of detail. That Friendship recently, as in let's say 5 years back, we had an idea of trying to start digitalizing the services that we perform. So before, the way Friendship used to operate was we have these ships, they're all paper records on the ship, and then we have paramedics who go out into the field. They're carrying like little booklets, providing prescriptions and things like that. And then we also have community health workers, or people trained in the field, and they're like local residents of those areas, and they also have like little booklets that they go around and they collect people's information and then they bring it back to us on the ship. So that was a really lengthy process, and there's room for many kinds of errors. So the idea that we had at Friendship was, okay, we need to figure out how to digitalize this. We need to make it error free, and we also need a way to start thinking at a higher level in terms of, okay, we can just for the next 50 years just provide services to anyone who comes. That's fine. But we can do more than that. We can actually track disease patterns. We can figure out how to be more efficient. So, but for those kind of things, you need to be able to actually track all your data in a reasonable way. And so that's where the digital solution came in. So we had a large project here, Friendship. So basically arming all of our community health workers, all of our doctors with digital devices, with smartphones and tablets and computers. We developed apps for them that are specific to them. So for example, the community health workers, they're local people from the field, from the local communities. So many of them have never used a smartphone before, first of all. So of course, they're not medically trained either. So the first thing was, okay, we're bringing a smartphone to them with an app. We need to design the app in such a way that the person who's never even used a smartphone can operate it. So the way we designed it is a little bit similar to the to BotMD that Dot was mentioning. It has like a chat feature, and we talk with we have doctors that are on the ship and doctors in our head office in Dhaka that are communicating. So it's not AI, but it's just regular people. And then it also has like a kind of like a flowchart design where you can imagine, let's say community health worker goes to someone's house, so it's like, okay, my head hurts. Okay, simple. His head hurts. What are the kind of diseases that might follow through from that? Or they might say, my stomach hurts. Okay, so if your stomach hurts, definitely that's a different list of potential issues that you can have, and you'll run down that kind of flowchart. And so then at the end of the app, it'll be like, okay, here's this over-the-counter medicine. You should prescribe them that. That's it. Or it'll be like, okay, you need to send this person to a doctor. They need to actually do a proper follow-up. It's okay. Then you take them to the shift. So that's like that's how we design that app. And then similarly on the ships, they have a proper kind of EMR equivalent type thing. Because it's a resource low setting, it's not at that level that you'd expect, in the big city hospital, but it's something. And all those apps are connected on the cloud. The data is shared. And then here at the head office, we have, data visualization tools that we can use to figure out, okay, at this time of the year, there's more of this particular disease. Then we can figure out, okay, there's more of this disease, we need more of this kind of medication. We also are starting to track climate data. So when there's particular weather conditions, then that means maybe potentially there will be certain other diseases that are more prevalent or less prevalent. And then, okay, so if that's the case, then for next month, we should prepare, okay, we need more of this particular medicine. So it's like all the decision making that needs to happen is basically impossible without data. You need data, and that's where the innovation for us really comes in, is how do we ensure we get that data in a way that is reasonable for these like kind of low income settings. Yeah, that's the main point that I wanted to mention.
Thanks, Shabab. So it sounds like the services that are being offered up by Friendship are very uniquely tailored to the environment that you are delivering these services in. At the same time, you're really helping to build that data set to keep on fine tuning the services as you go. That's really, really inspirational. So now I'd like to switch gears slightly and take the opportunity to ask our panelists to please share in the respective areas that you're tackling. What do you think are some of the current gaps in global health innovation that, if addressed, could help to significantly improve access and quality of care? Could I ask each panelist to perhaps condense their response a little bit and keep it within a couple of minutes? So we have time for Q&A at the end of this. Shabab, may I turn immediately back to you, perhaps, to keep expanding a little bit on your work on data tools or whichever part of what you shared now that you'd like to connect to?
So the biggest gaps, right? That's what you mentioned.
That's it.
Okay, let's see. I think the biggest gap for us right now is, I would say maybe an education gap. I think that's the one that we've been tackling right now. I mentioned before that our community health workers, they're, some of them, like the best ones of our, we have over 600 that we work with throughout Bangladesh. Some of the best ones, they have education level until, like grade 8 equivalent. So, they can read and write and they can do everything. It's just they didn't have a smartphone. So we gave them that and that's all they needed. The other people that are, almost like in terms of, you can call them literate because they can sign their own name and that kind of thing. But like that's the level that they're at. So it's figuring out how do we train everyone to get to a similar level of how to use those devices that we're providing them. Is it an issue of, okay, do we educate them, or do we need to design the device in such a way that kind of simplifies it, maybe more visuals, more, whatever it is. So there's that issue. And then also the other big challenge is sustainability. So, if I stick to the mobile phone issue, mobile phones are not cheap. Even the cheap ones are not cheap. But, if you just trip and you drop it into the river, that's gone. That phone is gone and you need to buy them a new phone. So you can't blame them for that. It happens. And especially the kind of places that they live, just from the humidity and the regular weather damage, the phone that maybe if I use that phone while I'm living in Dhaka, I could probably use that, let's say 8 years. They might be only able to use it for 4 or 5 years. And it's like, that's something you can't blame them for. So you can't force them to, like, if you consider them as like an employee of Friendship, you can't, hold them accountable for those kind of things. But at the same time, if they don't have it, then they can't participate in any of the services that we're, providing. So it's a matter of managing that issue, which is the biggest gap for us right now.
Thanks a lot for that. Let me turn it over to Dot. It sounds like you've been working quite a bit on different types of barriers, including adoption. What would you like to highlight?
Well, actually, I think the interesting one is maybe not from a patient funding side, but maybe from a healthcare provider point of view, right? Because I actually believe that technology is already widely available. And, to Shabab's point, like most people that I meet in the Philippines or Indonesia, they're on some sort of phone or chat app. But the funny thing, I think, is actually the adoption of technology needs to start from the provider point of view. Right. And that's usually where I see a lot of the gaps. So the challenging part is actually change management, right? So if, let's say, you were able to remotely monitor care, deliver, quality of care, the second question is then, like, who's going to do that, right? So do you have the scalability on the provider side to actually support what you want to be able to do? And the challenging thing, I think, is bridging that gap, because I don't know if you've ever walked into like an Indonesian clinic, a hospital, or even in the Philippines. I'm sharing photos, right? But like when you actually look at the level of technological capability, even with some of the providers, that's actually the gap. So it's not so much that the patient doesn't have a phone or, they don't have internet. They have. Question is, can you train the providers to actually deliver care using technology? So a lot of the work that we actually do when we go in to implement BotMD, particularly in public institutions, for example, Philippines, would be training healthcare providers, right? How to use it, how to manage it, what to do. So that's a very interesting area which people don't think about. So you can develop a great platform, but can you actually get a user to use it in the way that you want? Yeah, that for me would be the biggest one.
Oh, that's super interesting. Thanks so much for bringing that into our discussion. Alok, could you maybe share a few of your thoughts from health systems perspective on some of the main barriers? I know you touched on some of them before, but maybe building off the conversation here.
Absolutely. So building off the same framework which I talked to you about, I think the biggest need I see is that generally in medtech and in healthcare, innovation has been very centralized. You try to create something which is more solving, say, a clinical problem, and then you want to apply it to the whole world. While in global health, it has to be the other way around. It has to be decentralized innovation, which is in the context. And depending on which barriers are operational, you may have to innovate. So, for example, I was listening with a lot of interest to what Shabab was saying. I've been to Friendship about 15 or 17 years back. I remember going in a biplane with Runa Khan and dropping in the middle of the Brahmaputra and then seeing what you're doing. So if you think about what global surgery talks about, delay in seeking care, reaching care, and getting care, what they did is instead of the Muhammad going to the mountain, they brought mountain to Muhammad. So imagine. So the innovation was the ship. And I remember she got inspiration from her husband. But the point is that has solved a local problem there. The other one was very often when we have innovation, and I think the world is full of a lot of medical technologies and products, which quite frankly, few of them are used properly, and many of them are either declined or not used well, because they are no longer commercially viable for the US market or at that level. But sometimes if you go to a different context, you find that the same product, that benefit profile, though you might think it is very expensive for that market, may not be so expensive. Again, giving the example of Friendship, I remember on that ship having this conversation with Runa Khan. At that time, we had these sutures, which are absorbable sutures, which are more expensive than the silk, which is generally used for tying wounds. And I started talking to her, and she says, I would be very interested in that, because the benefit she was looking for is that this patient doesn't have to come back again to get the sutures taken out. Now, if you start thinking about the cost of reaching care is far more than the cost of that suture, suddenly your perspective changes. So I think decentralized, context-specific innovation, I think that in my mind is something which is a need and can be done. And the second is, I think, more about related to that, the innovation capability, access-based innovation capability to be there in the root. So I know a lot of the global health programs are run by usually doctors or some NGOs and stuff like that. But if they are able to, look at how do I see which is the area where I need innovation? Is it in training doctors? Is it in a type of product which is more market appropriate, which we can afford given our context? Is it in infrastructure? Can I get a different type of infrastructure? And then from there, finding a way, and which is where I think global health institutes can do a lot of work, is how do you create a way for them to share knowledge across? Because they have a need and the innovation in my mind exists. Like what Dot said, the Viber exists, WhatsApp exists. She didn't invent that, but the point is she innovated to solve a problem. So I think the ability to innovate, then look for what I can apply here, is going to be more important than trying to invent a new technology, which is how people have looked at innovation in the past.
Great. Yeah, thanks so much for sharing that. I think this really builds on a very rich discussion around different ways to approach innovation and think about the many layers of barriers. At this point in discussion, I'd like to ask our panelists to also share a few last thoughts on global health innovation from the perspective of looking forward. Where do we go from here? So currently we're at a place where there is ample technology that exists. Some platforms we can directly leverage, and in many conditions it would be around more on perhaps the challenges on the adoption and uptake side, or training providers, or really just getting a much more nuanced and insights into the data points that might be still keeping patients and populations from receiving the care they're looking for. So perhaps a little bit in that context of looking forward and where do we go from here. Could I turn it back to you, Alec, to share a couple of additional thoughts with us?
Yeah, so I think where we go from here, in my mind, we are at a very rich situation. We've got a lot of new technologies. AI is coming up, tele-mentoring, tele-health, all of these are possible. And I think when you look at global health, a lot of issues are around triaging to get the right patient to the right doctor even before he leaves home, because they're very far away. So I remember talking to this cardiac surgeon in India, Narayan Hudrale, Dr. Devi Shetty, and I'm talking about 2005, and he was using telemedicine. So I said, how do you do cardiac surgery with telehealth? Because I thought he's actually trying to do surgery with that. He says, no. He says, telemedicine is a patient acquisition and triaging strategy, not a treatment strategy. And he had actually gone to the Space Research Organization of India and told them, you've got a lot of bandwidth lying around doing nothing. Can you give that to me so that I can talk to my patients in Bangladesh and Indonesia and Nigeria and stuff like that, to make sure, along with their local GP, that whether this person needs to come here, does he need to be rushed, or can he be treated locally? And that, because his whole setup is based on throughput. So he says, if I get only the right people there, I don't have these masses crowding outside my clinic. And I remember that. I think it's also, there's a Harvard Business School case on this. And ISRO asked him, what bandwidth do you want? And he says, I need enough bandwidth for the patient to be able to see the compassion on my face. So the point I'm making is all these technologies are there, and I think Dot is doing a great job. And I think that is very much possible, even for, like I'm sure you're aware of Cost Africa and Surge Africa, how they use telementoring to upskill people so that they're able to do surgery, which they were not normally capable of doing, but because they have to, otherwise patients are dying, right? So all these technologies are there, and I feel layering AI on top of that would be very good, because it would be able to make a person get answers to things for which otherwise he had to go somewhere else. Maybe some of the AI-based diagnostics, I think a lot of things are happening when you're able to look at X-rays or other scans and get a quick diagnosis. I think there's a lot which can happen, and I think all of it, in my mind, is applicable to the area of global health and global surgery.
Thanks, Alok. Well, with that lead in, I think I'd prefer to hand it directly over to you, Don, to maybe build off those points. And yeah, if you also want to be nudging us towards what AI means for leveraging access or any other avenue you'd like to go down in your thoughts before we open up to Q&A.
Sure. So actually, I think right now is actually a super exciting time to be doing global health. One, in terms of the impact that you can have, right? Because the great thing about global health, and this is what draws me towards like a lot of the regional countries that we're in. We're talking about 300 million people in Indonesia, 100 million people in the Philippines, like easily, if you just combine everything in Southeast Asia, how much impact you can actually have, right? Part two, what's exciting about it, I think, is that the time for technology to meet healthcare is there, right? We've never actually had a situation where it's so easy to build stuff without code, right? Like, I mean, I was seeing, I don't remember this morning, I saw an article talking about like, it was an Instagram ad. So it's an Instagram ad for people above the age of 40 who want to learn how to use AI. It's really funny. I was being targeted, so anyway, but
You're the wrong target audience.
So the interesting thing is that you can actually build stuff fast.
Yeah.
Right. And then the ability to actually try it out and iterate and like prototype. I don't think there's ever been an era where like technology and the need are almost, hand in hand. So to me, actually, like, if you are thinking about going to global health, like this is the time, right? Part three, I think it's really thinking about the way in which you actually want to design stuff. How do you involve and try it out quickly? So one thing that I see a lot, particularly in Singapore, would be that we don't get enough feedback from the countries that we actually want to go into. So when you build, right, you don't just need to build it, you actually need to iterate fast, right? Too many times I see people getting grant money and then they build stuff and then they go out and they realize like whatever they just built doesn't actually work. So how do you actually use tools that are available to innovate quicker, right? And then be able to actually go out into the region and actually test, right? So those would be the three things for me.
Oh, thanks a lot, Doc. That was great. Shubham, before the Q&As, it sounds like your organization, you're working in quite an agile way to keep on updating the way that you deliver care to the populations you serve. Do you want to paint the picture for us of how you would keep on leveraging the innovation you're doing to improve that?
Sure. I think the biggest issue for us now is when we, for example, if I talk about our digital systems again, when we started designing those, basically no one was talking about AI. I don't like AI in the healthcare space was really not there. And so we didn't design it in that way. And so now we have an issue where, okay, we have real doctors that are communicating over the phone through this app with our people in the field. But the kind of diseases that we're talking about, they're not even like really diseases. They're very simple stuff. It's just because of the lack of access that we need to, handle these things. But they're relatively simple to treat. So we don't need like a fully trained doctor to deal with that kind of thing. So I think that's like one of the things where like AI and those kind of tools would help us be more efficient, figure out, okay, these are the things that we can handle quickly, with AI or however it is. And these are the things that, okay, this is where we can dedicate more of our time and energy. So that'll help us, manage our resources better, be more efficient, and then be able to expand our care to people who really have no access. And those are the kind of things that we're thinking about now at Friendship.
Fantastic. Thanks so much for sharing that. So now let's try to move into the part of this conversation where we're opening up more to questions from our audience online. So we're opening that window now, and if you want any particular of the panelists to be tackling your question that you're sharing with us, please mark that out in your question, and we'll be directing that to the right panelist, of course. So I think we have questions coming in. Not quite yet. Okay. Well, I have one that I can start to warm us up with. What skills or mindset do current healthcare professionals need to develop in order to be prepared to tackle future healthcare challenges? And where does that connect to innovation? Maybe Alok, any thoughts on that you could share with us?
Yeah, no. So I think one of the keys to tackling healthcare challenges is understanding them well. And I would very strongly urge, and this is because I have worked most of my life in a decentralized organization where there used to be a saying in our company which said, "Your desk is the most dangerous place to watch the world from." The point is going to these places, and I think especially if you are in comparatively well-to-do markets, it's very important to go and really appreciate the context in which the problems exist, what it feels like there. And then along with that, of course, will come cultural sensitivities, regulatory things, and whatever is there. But those are very important part of implementing global health innovations. It's not just about solving a healthcare problem. So I very strongly feel that is something which is going to be very important. How to develop a good feel for what goes on at the place where the problem is. And the second I feel is that more and more we need to start focusing not on individual patients, but on patient groups, because each of these patient groups, in my mind, follows very different barriers and opportunities. So for example, a trauma care. I mean, if you look at bellwether procedures in global surgery, the compound fracture, the type of things that needs, the skills it needs, the external fixators and all of that, is a very different supply chain, skill chain, and everything else compared to, say, maybe laparotomy or C-section. So starting to look at, whole, areas like that, and then seeing innovations and then sharing that might be more meaningful and easy to do rather than trying to bung everything together, because healthcare is very complex. You go to any hospital and you realize it's like a, ant hill, where everyone is going in some purposeful direction, but no one really knows what's going on. They're very, very complex things. So being able to unpack the focuses, being able to unpack the streams in which you want to work, I think is a skill which, and again, you learn that only when you go into a context. Trying to do it at one level doesn't work because every market is very different. Every geography is quite different.
So really understanding the localized patient care pathways in detail,
Yeah.
and before you start thinking about how to innovate to ameliorate. Yes. Okay, thanks. We are getting additional questions online. So let me share this one. What are strategies to collaborate with the government to bring in innovations in the Philippines or Bangladesh? So this one is intended for Dot and Shabab. How do we get government to be supportive?
So let me answer that. Actually, I find the governments to be very supportive already. In fact, interestingly enough, in both the Philippines and Indonesia, actually, be surprised at how much the government does to fund global health or impact type projects. The challenge that I found is not so much getting the government to be supportive, but sometimes, in the Philippines in particular, when they change government, that becomes very, very, very disruptive, right? So it's not that the government doesn't have money to fund these projects, but when they do switch governments, then it's it actually disrupts a lot of the implementation work that we do. But I haven't actually seen where, when you go to the government with an idea to reach primary care, right? So we were doing a project, for example, in the Philippines around HIV, right? And the government actually came to us saying, hey, we want you guys to figure out how to help us reach more HIV clients in a way that we cannot do today, right? So weirdly enough, there's funding, But so it's not the funding that will be the problem. The main challenge a lot of times is actually the implementation of it, right? And I think that's what Shabab said too, right? You got to figure out like, how are you going to roll it out? Like, actually go on the ground and see, right? The infrastructure that you actually have. Yeah.
Thanks.
Yeah,
That's
sure. I can,
helpful. Shabab.
yeah, I can add to that. I think, yeah, I definitely agree with Dot, where I think in Boundless as well, it's really the government is definitely supportive. I mean, they want to be supportive and they are understanding of the situation. So one thing, the interesting thing about Boundless, as I mentioned earlier, like the actual infrastructure is good. And for example, there are government healthcare workers in various fields, right? In fields as in like in the rural areas that are doing work. But it's just not enough. They don't have enough funding. So that's where the NGOs come in, like Friendship or BRAC or whoever. We also have our community health workers who are just working in a slightly different region than where the government is working. If the government have a community clinic, we also have our ships that are in the area where potentially there's no government service. So it's a kind of just a matter of communication, like that, okay, we're here. They might, if we have some kind of innovation, it's like, okay, the government is like, okay, how do we tell the government that this is what interesting thing we're doing? And then how does the government figure out a way to also bring that to their workers as well? And that's for Friendship. One of the big things that we're working on right now is of our 7 ships, 5 of them are part of a particular project that's being funded with the purpose of potentially in the future handing it over to the government. So we're working in collaboration with the government to show, okay, these are how we operate our ships, and that's how we've been operating our ships for the last 20 years. Learn from us, and then after 5 years or so, we'll hand it over to you guys, and then you guys can, continue on as well. So that's the kind of thing we're thinking about.
Thanks. That's great. So I think we have time for one more question from our audience. And as we know, innovation can be costly. And we just mentioned how implementation is really where the rubber hits the road. And that can be quite resource intensive as well. So this question is, what about funding? What are some of the areas of funding to implement innovation in regional markets? Anyone would want to respond to that? How do you tackle getting some of the needed funding in your respective areas? Where do you turn?
So for me, typically, if we're doing government projects, so usually for government projects, the government will have budget. I think the challenge at the moment is that, particularly in the Philippines, where a lot of the budget actually came from US aid. Knowing the situation now in the US, actually a lot of that funding has dried up. But there are, vehicles like the Asian Development Bank, right? The WHO. To be honest, actually, if you just even, talk to ChatGPT about this, you'll probably get some ideas on where to go for funding. To me, actually, I think the way that I like to think about it is like, how do you, let's say you do get funding, the question is, how do you actually pilot something at a relatively low cost? Right. So there's 2 parts to thinking about funding, right? You need funding to get going, to try, and then you need funding to scale it up and actually be sustainable. These 2 things are actually very different. Right? Arguably, you actually don't need very much money to actually start and try.
Yeah.
And I think that's really where lots of grant money is out there, right? It's available for you to actually prototype, pilot. And then subsequent to that, if you actually go to a much larger organization like an ADB or a WHO, right, to scale it up, they would want to see why you believe it's going to work.
Yeah.
So that would be the way that I would think about funding. Yeah.
Yeah. One additional point I would add to that, what Dot just said, is that because this is global health, this funding is not a short-term thing. You need funding and an organization which will continue this when you leave. So it's not something you can do and say, okay, I've done my job in 1 month or 1 year, I'm leaving. So there are some models, and I think the one which impresses me most, because we were very closely involved with that, is Operation Smile, which was a global program started with Johnson & Johnson in Manila in Philippines. And we got this plastic surgeon, Dr. Bill McGee there. And he came like that. He said, I'll come, maybe I'll do some, cleft palates. and I'll go back. And when he talks about it, he is actually in tears most of the time when he tells that story. He says, when I had finished, there were 200 people still waiting with their children and said, we need this. And they had all the baskets of bananas and other fruits and all for it. And he said, I cannot just go back. So that's where it started. And Johnson & Johnson started funding this. In fact, they used to provide all the sutures. And when I was in J&J, I remember we used to run this as a corporate contributions program where we would contribute. We would have like chess tournaments, God knows what all we did to get money in. And then, of course, the corporation would match it. So I think the key is, how do you find a host organization for something like that? And which is why I'm very particular that you find a need which can, tug at some emotional, chords, like Operation Smile. I mean, the difference it makes to that little girl in her whole life changes with that cleft palate is huge. It's not life-saving, but it makes a lot of difference to them. Similarly, we've done things in breast cancer in Singapore itself, where we had the Mammo Bus, J&J with the Asia Pacific Breweries at that time. So I think you can find people, and most corporations are quite ready to participate. But you have to make this story, and it has to be something which appeals and carries through. You can't just say, I want money and go and do something. That is short term, but I don't think it'll continue for long.
Thanks so much. That's very inspirational. Okay, so for any attendees here on our call where some of this discussion has sparked more interest in getting to know and understand more about how to innovate for global health, I'd like to encourage you to fill out our expression of interest for the SingHealth Duke NUS Global Health Innovation Graduate Certificate. We will try to bring some of this information up on slides now on the screen. At this point in the conversation, I'd like to thank the panel for sharing all of your rich experience from across sectors and geographies. I think we've covered so much ground during this discussion around how important it is to really understand the context in detail, to fall in love with the problem and really start picking it apart. And once you have some of that understanding, don't be afraid to dive into it. Dot highlighted the importance of iteration as you go. And from Shabab, we also heard about the importance of getting that data back to continue to refine and make sure that whatever you're offering, whatever you're innovating for, gets more and more honed in on the problem that you're innovating towards. So thanks so much for all these insights. I think this has also underlined how this discipline of innovating for the global health context requires grounded insight, systemic thinking, and the courage to experiment and collaborate. So with that, I would also like to invite everybody in the audience to please join us for Module 2 and all the other modules of our graduate certificate in global health innovation, where we'll go deeper into these themes and equip yourself to design, lead, and implement innovation for global health impact. I'd also like to mention that there are some scholarships available if you happen to be from within our academic medical center. And in case you're not, feel free to reach out to us, and we'll be very happy to follow up with any additional questions that you might have. Back to you, Ashley, and thanks for all your time.
Great. Thank you, Jonas, and our panelists for the engaging session. And thank you to you, our attendees, for being part of this webinar. If you have any questions, feel free to send them to us and we will pass them on to our panelists so you can take those conversations offline. As Jonas has mentioned, the Grad Cert in Global Health Innovation is currently open for registrations, and it's a very unique Grad Cert, and we'll dive into the topics that were touched upon in this webinar in more detail, taking a holistic approach to global health innovation and empowering participants to transform their innovation ideas to reality. So we'll leave this webinar room open for a couple more minutes for anyone who has queries about what was talked about during the webinar, but also about the Grad Cert. But if not, thank you once again to everybody for spending your lunchtime with us, and have a great rest of the week ahead. Bye-bye.
Thanks.
Yeah.